Hello, I'm Dr. Robin Miller, and you're watching HealthDay's conference coverage exploring research with the world's leading medical professionals. The theme for this year's American Society of Clinical Oncology annual meeting, selected by ASCO President Eric Weiner, asked attendees to look at how interactions between clinicians and patients have changed over the years. Today we're joined by Dr. Weiner, who shares highlights from the meeting and just how practice-changing this year's research is. We're also joined by key experts who share details on research they presented at this year's annual meeting.
This is a year when we have multiple practice-changing studies. I would actually argue that we probably have more that is changing as a result of this year's ASCO meeting than ever before. One of the studies is a study in patients who have rectal cancer, where the standard treatment in the United States for many years for patients who have stage 2 and 3 rectal cancer has been the combination of chemotherapy and radiation and surgery. What the investigators did was they randomized patients to either receive that 3-modality treatment or to have radiation omitted if the patient was responding to chemotherapy. And what they found was that omitting radiation in this group of patients, as long as the patients were responding to chemotherapy, and most were, was an entirely safe approach, that patients did just as well and had fewer side effects that were, of course, related to the radiation. I think one of the important aspects of this study is it speaks to the fact that as our cancer therapy gets better, there are going to be an increasing number of situations where we say, we're doing really well by patients. Do we have to do as much? Is there a way of peeling back a little bit of the therapy so that the therapy is that much better tolerated? And this is one of several studies like this being presented this year, but I think we'll see more and more of these to come. We obviously need to be very careful when we eliminate therapies or back off on therapies. We just want to make sure that patients, from the standpoint of their cancer, do every bit as well. There are 3 other studies I want to touch on. One is a study in patients with Hodgkin's disease. This is a very important study because it was done in both children and adults. And in this study, they looked at the use of a checkpoint inhibitor or immunotherapy as the initial therapy in combination with chemotherapy for patients with Hodgkin's disease. And what they showed is that compared to what is presently the standard, patients who received immunotherapy had a better outcome, had fewer recurrences, and this is going to immediately make immunotherapy, because it's widely available, a standard for patients with newly diagnosed Hodgkin's disease, similar to the patients who are in the study. The other 2 studies, one is a study that focused on patients who had brain tumors, and these are called oligodendrogliomas or low-grade astrocytomas. Patients will typically live with them for many, many years. But in this study, after surgery, half of the patients received no further therapy, half of the patients received a new targeted drug that is focused on what is called the IDH mutation. And in patients who received the new targeted drug, there was a far greater time until there was a recurrence of the cancer, which allowed them to delay other toxic therapies, treatments like radiation and chemotherapy. And so this too will be a drug that gets incorporated into U.S. practice very, very quickly. The last study is a study in lung cancer, in what's called EGFR positive lung cancer. And in this study, patients were randomized to have either surgery alone or surgery followed by the drug called osimertinib. This is a drug that inhibits the activity of EGFR. It was given for a total of 3 years, so it's a long course of therapy. But as a result of getting osimertinib, patients had not only fewer recurrences, but also had a significant difference in terms of their overall survival, so they were living longer. And the importance of this study is that there are many countries around the world that will not approve a drug for use in this type of setting unless there's an improvement in longevity and survival.
My name is Amr Zaidan. I'm an associate professor of medicine at Yale University, and I direct the leukemia program and the hematology early therapeutics research at Yale. Imetelstat is a first-in-class telomerase inhibitor. This is a drug that's given by injection intravenously every 4 weeks. And phase 2 data from the same study, from the IMerge study, has shown that among patients with lower risk MDS after ESA failure, who are heavily transfusion dependent, that the transfusion independence rate is around 40%. So the phase 3 study was conducted, it's called also the IMerge, it was conducted to look for this activity against placebo. So patients were randomized in a double-blind fashion to receive imetelstat or a placebo, and those patients were heavily transfusion dependent, so they had to have more than 4 units per 8 weeks of transfusion at baseline. The median transfusion dependency was actually 6 units, and the response rate was actually in line of what we have seen in the phase 2 part of the study. So around 40% of patients achieved transfusion independence compared to 15% in the placebo-controlled arm. So the activity was actually quite good and quite durable. That was very important as well, is that the median duration of transfusion independence was more than 50 weeks. So both high rate of activity and durability of activity. In terms of the side effect profile, it was very similar to what was seen also in the phase 2 part of the study, where the main side effects were thrombocytopenia and neutropenia, as well as liver enzyme abnormalities. The liver enzyme abnormalities were mostly grade 1 and grade 2, generally reversible. No highs, low cases were detected. For the thrombocytopenia and neutropenia, most of the cases were also reversible and manageable by dose reduction and growth factor use. And importantly, the clinical consequences, severe clinical consequences of bleeding and infection were not increased on the intervention arm compared to the placebo arm. So we did have recent approval of other agents, for example, luspatercept for patients with lower risk MDS after ESA failure. But the problem is that luspatercept has been approved in patients who have ring sideroblast positivity, which is a fraction of patients with MDS. Imetelstat has activity across the spectrum, and the activity is generally with most agents, the drugs tend to stop working after some time. So I think having another agent will be very important to help our patients, because patients with lower risk MDS generally are not cured out of the disease, and they are going to be always dependent on some kind of treatment. So it's going to be sequential therapy with the goal of optimizing their quality of life and keeping them out of the hospital and reduce complications of anemia as much as possible. One, making these drugs available to patients at earlier stages of their disease. So before they become even transfusion dependent, when they are deeply anemic, but they are still not transfusion dependent. And the second area, I think, is combinations, because monotherapies can help, but that, as I mentioned, the activity tends to be limited and not very durable for most drugs. So the idea, if when you combine drugs that have good activity but non-overlapping toxicity, is to increase the rate of transfusion independence, prolong the duration, and hopefully also minimize the increase in any side effects. So other drugs are being studied in this space, and I think it's a very good year for MDS with 2 positive phase 3 trials for lower risk disease, and hoping to see the same in higher risk disease in the near future.